So good morning. I hope everything worked correctly this morning. Some of this I can see, some of it I can't on our switcher technology. You know, I'm working a lot with employers helping folks get back to work, and employers as well as governments share a significant challenge because they have some responsibility to create a safe environment for employees and citizens. But in order to protect employees and citizens, you have a delicate balance between, okay, where am I impinging into that individual's rights, such as the right to privacy? So, as you might imagine, there are different workplaces and different governments that have very, very different records of performance in this area. Obviously, China comes up as a government that is not the best about protecting their citizens' rights. So we're going to talk a little bit about that today in terms of contact tracing apps. Upcoming topics: fewer people doing social distancing already before the states are making their changes in recommendations and regulation. You can see that from cell phone app information. We'll talk about that a little bit more. Next Tuesday, we'll have Doug Thompson come on and tell us about how dentists can protect you if you go into the dentist's office in the age of COVID. A little bit more information about the mutation rates of these viruses and some Los Alamos information indicating that there may have already been a significant mutation that we're just now finding out about, or they're seeing evidence of. Can herd immunity be achieved without vaccines? There was an interesting interview of the doc in Sweden, or the government official in Sweden who was responsible for their policy. He admitted, you know what, we got a lot more deaths in what they call care homes than we expected. And then the next question is, well, so are there any adjustments? Next topic: coronavirus may have been in circulation long before it was identified. Well, that's usually the case. That's usually what happens. So some more interesting information coming up next week. For those of you who haven't seen them, we've done topics, obviously treatment. We've done topics on COVID-19 in children, the race for the COVID-19 vaccine. That was a very interesting article for those of you who are into the science of vaccines. And as usual, there were your predictable number of vaccine haters who made some comments about it as well. Talked about the mysterious blood clotting problems where young people, otherwise healthy, are getting major strokes, losing a leg, like the young healthy Broadway actor that lost a leg. Pulse oximetry. And I'm continuing the saga of trying to get my little pulse oximeter that I got last week from Amazon, trying to get that darn thing to work. Still haven't gotten there yet. Remdesivir, as we've mentioned, it's worth covering a few times in just real quick snippets. Maybe a 30% decrease in hospitalization or in hospitalization length, 30% decrease hospitalization length, maybe about a 30% decrease in mortality. For those of you who need help in terms of urgent care, we do have some slots available on a telemedicine perspective. Most importantly, for those of you who are wondering, do I have these same things that put me at risk for COVID-19, this serious illness and death, if I get coronavirus, if and when I get coronavirus or SARS-CoV-2 infection? Most of us don't know. Most of us that have it don't know, as in over 90% of us. But it's not that difficult to find out, and it's not that expensive. See IMT webinar. If you've had an IMT, you didn't know how to interpret it. You didn't know what the risk estimators meant. You took it to your doc didn't either, and your doc said, I don't use that, it's not any good. Well, you may have a different perspective, and again, it's you can find out. We can help you do that. Still working on the book. I'll hear from Todd, I expect, over the next couple of weeks as we get closer to the end of that final draft. Simple, one-sentence summary. don't depend on a stress test to predict a heart attack unless you're feeling really lucky. We go into depth on why that's the case, and we go into depth on what you can do better. You can clearly predict heart attack and stroke, but the current way of doing it with just a stress test doesn't work. So we'll get back to return to work and return to society. And most importantly, today we're going to focus on contact tracing programs and applications associated with contact tracing as we get into this next phase of the coronavirus pandemic, right after Aspen gives us the water ball. So here's a question.
You mentioned,
is the U.S. ready to contain COVID-19 or the coronavirus pandemic with contact tracing? Well, first of all, you have to have adequate and appropriate testing, both antibody testing and PCR, virus or viremia testing. And there's been a huge improvement in that space, but it's still not where it needs to be. There are other issues as well. Let's talk about it. Contact tracing is what is it? It's a time-consuming process of tracking down associates of people who test positive for contagions. Not just associates, but others who may have been infected. It is seen as a key to a safe reopening. Again, those of us who think that we're going to achieve a practical, pain-free herd immunity, you need to study the details a little bit better. How time-consuming is it? Well, again, let me go back and say, contact tracing is nothing new. We've done it in the TB world. We've done it in syphilis. We've done it with other things as well. So actually, I had a family member a few decades ago who was a, quote, VD investigator, a venereal disease contact tracing expert. And you're basically talking to people who've had a venereal disease as documented by testing in the public health department or other departments. It was mandatory reporting to go find who they may have had contact with. In other words, who they have gotten the disease from and who they may have given it to. It's the same thing for coronavirus, except very, very different mode of transmission. So many public health experts say the country's underfunded. Patchwork of contact tracing systems just isn't ready to handle the challenge of an epidemic. And I can tell you from my experience, that is a massive understatement. Next bullet, the U.S. needs at least 100,000 contact tracers and $3.6 billion in funding. I think that's probably an accurate number. At least it's a good start. We don't have the scale that we need. We don't even have close to the scale that we need, according to Crystal Watson, a senior scholar at the Johns Hopkins Center for Health Security and an assistant professor at the Johns Hopkins Bloomberg School of Public Health. Now, what about technology? What about apps? What about Singapore? What about South Korea? What about China, other countries that have done this? Well, let's look a little bit deeper at the application. You know, as they used to say when apps started becoming popular, there's an app for that. Well, there are apps for this as well. Google and Apple teamed up to build tools and track the spread of coronavirus. That was announced on April 10th. Google and Apple said that their work would come in two stages. The first one being release tools for application programming interfaces, or called APIs, so that the apps could work on both iPhones and Android phones. So that's a major start. Then you got to get the apps, right? Build a voluntary tracing system directly into the two operating systems. Yep, you've got some of that already, and that's what some of these statistics are on, come from. That's where they come from. These voluntary tracing apps, where people are saying, yep, you can trace my information. I want you to keep it confidential, showing that they're already getting out. People are already getting out into the marketplaces, the workday world, out into public, whether their governors and states have opened up or not. So the third bullet, versions of coronavirus tracking apps already exist in China, Singapore, Israel, South Korea, Taiwan, and elsewhere. But efforts have been slower in the US, UK, and the rest of Europe due to some reasons that are obvious to most of us. Number one, privacy concerns, and the contact tracing must be combined with widespread testing. And again, that gets back to statement number one, we haven't had widespread testing availability yet. Pardon me just a second. Wuhan, China opened its borders last month. The government's surveillance app is needed to enter and exit the region. You see that picture of that individual getting ready to get on a subway. In order to do that, he has to load the QR. I'll read about that in just a second. The surveillance operation employs advanced technology like GPS tracking, artificial intelligence, and facial recognition. So while the app helped the government relax lockdown measures and reopen the economy, there are concerns that this temporary measure might become permanent. And again, I have every expectation that that's the case, for what that matters, with what I believe. But again, I think that's the issue. Leading human rights advocates also fear this will be used as a convenient justification to expand the monitoring of the population, especially human rights advocates and political protesters. Here's how China's system works. Individuals were required to register for a QR code through WeChat or Alipay. Alipay is Alibaba. It's, isn't it like, what, multiple times the size of Amazon at this point? Users have to enter personal information like ID, phone, address, when and how one entered into the region, where they stay, and the purpose of the trip. So again, if you're a critic of the Chinese government, that's actually most of that information may already be in the hands of the government anyway. A series of health-related questions. Do you currently have any symptoms for COVID-19? Have you been in close contact with COVID-19, with a COVID-19 carrier? Then based on the responses, the app generates a color code. QR scans are required upon entry or exit. So we've got a quick video. It's about 2 minutes. It goes into not only China's, but a couple of the other countries and what they're doing in this space.
Martin, you're right there, and you mentioned China, and I'll start with that example because what I've seen here are some really striking examples of the mass surveillance apparatus really being mobilized by the government here. I've had a couple of sources tell me CCTV cameras have been installed outside the doors of their apartment to check that they're not breaking quarantine. You've got the government here also using drones to tell people to keep their masks on. On top of that, mobile QR codes can tell you the health status of an individual as well. When you enter the building, a guard might ask you for that QR code, that digital barcode on your smartphone. Those are some very extreme examples you're seeing in China, and what you're seeing outside is perhaps elements of that, not as extreme. I'll kick off with Singapore, for example. They have an app that uses Bluetooth connections from phones to talk to each other and essentially map out the movement of people in order to trace out and prevent the spread of the coronavirus. In Hong Kong, wristbands on people that hook to a smartphone and alert authorities if you move outside your quarantine space. In Singapore, in South Korea, they're using things like credit card transactions, CCTV footage, and mobile data to map out the movement of people. In that kind of case, it's pretty worrying because there have been concerns that you could identify individuals. Over in Israel, for example, they're also using mobile phone data to track the location of people and potential carriers of the coronavirus. And this has caused huge concerns from privacy groups on a number of levels. Firstly, as I mentioned in that South Korea example, is how quickly or how accurately could you identify an individual from the public information that's available? That's a big concern. Secondly, how long will this data collection last, and how long will these governments be holding the data for? For their part, some governments have come out and said, well, we're only going to do this as long as the coronavirus is going on. But again, we just don't know how long this is going to go on for and how long they're going to hold that data for. And lastly, even after coronavirus, will governments keep this heightened level of surveillance? That really is the biggest concerns among privacy advocates, that whether this is a pretext for heightened surveillance around the world, a trend that we have been seeing rise globally over the past few years anyway.
So there you go. Interesting topic, but something that's not going to go away. It's going to get bigger, obviously. Jackie Shaheen, good morning, Doc. Good morning to you, Jackie. Robert Simpson, good morning. Thank you so much, Jackie, for starting us off with a contribution. We appreciate that greatly. And Alan Cruz as well. Thanks, Alan. I appreciate it. And then we got Dave Murphy. So once again, we appreciate all of you and all of what you and your team are doing. Thank you again so much. I hope the information is helpful and obviously appreciated. It makes a big difference for me and for the team to see folks contribute like that, to let us know that, you know, there's so many free sources of information, and ours is free as well, but we're doing what we can to get information out that's truly life-saving information, not only with COVID-19, but again, with the major risk factors associated with death from COVID-19. And that is prediabetes, most often totally unrecognized prediabetes. So thank you again, David, Alan, and Jackie. Douglas Pohl, add credibility to your presentations by subtitling with a reference. Example, starting death stats. Your choice is always. Thank you for your sharing. So we get a lot of questions about the death stats. Here's the information, Douglas, and I think you may have asked this yesterday. The coronavirus numbers are obviously coming from Hopkins and couple of the other places, which are in turn coming from WHO and national sites. As we've mentioned, every piece of public health data has its own pluses and minuses. Now, regarding and Carl, if you could, you and Aspen, Chris can help you in terms of giving you the reference for the for the COVID-19 reference. Douglas, the real question is the heart attack and stroke numbers. There is no weekly heart attack and stroke public health information that I'm aware of. As I mentioned yesterday, I covered some of the reasons for that and some of the concerns and the situation on that in the upcoming book. So the bottom line is we have to go back and basically extrapolate based on the most recent annual data. That's what we've done. Now, one of the major challenges with that data would be this. The same people that would have had heart attack and stroke are also people that would have died from COVID-19. The point behind it, though, is even in the height of the COVID-19 epidemic, you still see the killer is not so much SARS-CoV-2, that virus. The killer is undiagnosed prediabetes. So I hope that helps. And Carl, maybe you guys could make a statement about that as a little reference under the cardiovascular numbers as well. Guten Tag, Herr Doc. Guten Tag to you too, Joe. Thanks for joining us. ML, morning from not sure where. From San Diego. Seems the death numbers may be challenged. Your thoughts on the subject? Do you feel they're accurate in the U.S.? Well, as I said, I think the death numbers from COVID-19 in the U.S., if you look at public health numbers, they tend to follow the economy of the country. The better the economy, the better the information that comes out. Now, there are other determinants as well, which we all know. So, for example, I have a major, and I think most of us do, have major reasons to mistrust data coming from China. I think one of the questions you may be asking specifically as well with Senator Scott, I'm blanking on his last name, and others talking about hospitals getting paid more. If they label a death as COVID-19, then are we over-reporting COVID-19 and under-reporting other things like the cardiovascular deaths not related to COVID-19? We covered a lot of that yesterday. The topic was, the title went something like this: even prior to COVID-19, either 1 in 3 or 2 in 3 of death certificates were inaccurate. And it's getting worse, a lot worse. Now, that was a quote from one of the experts on national health statistics. This was not an expert on physiology and preventive medicine and chronic disease. It was not somebody that you can expect to know that, you know what, most heart attack and stroke is due to pre-diabetes. It's due to plaque, and most plaque is due to unrecognized pre-diabetes. So my perspective is he would stop and say, if 1 to 2/3 of them are accurate, most of those are going to be labeled as heart attack or stroke. And I know that heart attack and stroke is not the primary event. It's not really what killed the person. So from my perspective, the death numbers, the death rate numbers basically just go from bad to worse. I do not put a lot of credibility on on details around any of these numbers. I think one of the things that you can do, though, is look at overall larger trends. It's, for example, some of the information that I've gotten asked about already. Well, Brewer, where did you get the numbers for COVID death rates and for heart attack and stroke death rates? Again, we've covered some of the challenges in both of those points. But again, I don't think either one of them gets away from some of the overall most critical points. And that is, yes, COVID-19 is killing a lot of people. There's no question about that. Has there been a massive increase or decrease in the seasonal flu? No, I don't think there has. I think there's some good information indicating that that's not really the case. How many people that would have died from heart attack and stroke are actually being labeled as a COVID-19 death, either accurately or inaccurately? I don't have a good handle on that number. But again, I think we all know this: COVID-19 is killing a lot of people. Number two, heart attack and stroke have been killing a lot more people for a long time. And in many ways, most of us have been okay with that. It's not that we're okay with it, it's that we assume that it can't be changed. And that's the problem. The vast majority of heart attack and stroke deaths can be predicted and can be prevented. So thank you again for that question. Joe Riley, Doc, thumbs up on a very important to YouTube standings. Ask everyone, well, thank you. Thank you, Joe. You know, I've read that many times. If you'll do a thumbs up, any kind of interaction, if you do a thumbs up, even if you do a thumbs down, that encourages the YouTube algorithm. It does that because it sees that and says, you know what, maybe there's a little bit of what's the word I'm looking for? Debate going on here. So thumbs up, thumbs down, but most of all, shares on social media like Facebook. Any of those things really send a strong signal to the algorithm, that the YouTube algorithm, that this is important information. Humans are referring it to other humans instead of, and then the machine's just going to follow suit. Dave Murphy, I watched the Dave Sinclair video. Interesting. Caught a brief mention of stem cell therapy. What are your thoughts on stem cell therapy? Not for COVID, but other applications. Well, thanks for mentioning the David Sinclair video. So I'm assuming you're talking about mine. A couple of points about it. As you might see, we're trying to develop a system where we can provide more clips that what we would call an interest clip or almost a B-roll kind of thing. We cut it to, we're also, as you've seen, I'm from the South, so I have a lot of awkward pauses. So we're trying to cut some of those out. We got a little too aggressive on that. Overall, I think we're moving in the right direction in terms of our editing processes. The bottom line, though, is what was the content? Yes, the content I've covered in other videos. I've actually done a series of about 8 or 9 videos on David Sinclair and his book, Lifespan. It covers the mitochondrial theory. It covers senescent cells or zombie cells. It covers his information theory of aging, which I think has a lot of credibility and actually is likely to unseat the mitochondrial theory as the #1 theory behind mechanisms for aging and death. Now, another one, I'm blanking, the telomere length. That's obviously one of those mechanisms as well. So again, there are about 8 or 9 of them. And I went into depth on each of those mechanisms, as in each of those chapters out of the book Lifespan. Now, that's a brief plug on the series on Lifespan and the video that we just did as a summary for him and that topic. Your question, though, is what about stem cell therapy? I've got a series on that too. Here's the bottom line. Stem cell therapy is not quite ready for prime time, mostly for a couple of reasons. The biggest is that it's not standardized yet. There are multiple ways of getting stem cell. You could get platelet enriched plasma. Now, what is that? That's not exactly stem cell, but it does appear to include include some components, some biomarkers, and maybe some signaling markers that actually may create or stimulate the body to create stem cells. There are questions and lack of standardization on how to get stem cells, where to get them, what sources to use, how to prepare those stem cells after you get them out, where to inject them, how to inject them, what are the standard levels of stem cells that you need. So when you don't have standards around any of these things, somebody does a study, you don't really know what you got at the end. One of the typical and big studies was use of stem cells in knees for cartilage, regrowing cartilage in people that had bad knee arthritis. Here's what they ended up finding. They ended up finding a huge improvement in the people that had stem cells, but guess what? They had the same level of improvement in the people that got placebo. So does that mean, what does that mean? And we could go into a lot of detail on that. But again, I think it basically just underlines that, yes, we can make a lot of trials. We can, it sounds very exciting. It sounds like in many ways the fountain of youth, but it's not ready. It's not ready for prime time in terms of, we don't know what we're doing with it. As a society, as a medical group, it's just a lot of experimentation right now. And it's not great experimentation yet because it's not standardized. So we're not learning as much as we could if we did have standards. So it's a great question. Thank you, Dave, for asking. I also caught a brief mention on another channel of upcoming availability of home insulin testing, similar to glucose real time. Have you heard anything? I haven't. That would be such a big, big deal because, you know, I use the, I have one on. I'm not going to roll my sleeve up. I have the Libre. It's a great a new picture. I had a patient earlier this week just sing its praises in terms of, yeah, I know there are problems with the exact numbers, but I'm finding out so much about my patterns. I never knew I dropped so low down into the 50s routinely in, you know, 3 o'clock, 4 o'clock, 5 in the morning. I never knew I could handle a spike after eating until using this thing. I never knew I was having spikes. You know, so they got a lot of information, but meanwhile, as helpful as all of that might be, it's still not telling us about insulin. If and when we get to an insulin tracing device, that would be huge. Because at least a couple of people per month now coming into me will have basically normal glucose patterns, but take twice or more the amount of insulin to do that level of control for their glucose. So again, that would be a huge, huge improvement. Good point, Joe. Thumbs up on all the videos. Thank you, as both of you, Dave and Joe. Thanks for the suggestion. I started to actively share on YouTube and will continue to do so. Thank you. I do appreciate that. Share on Facebook, not YouTube. Okay, I agree. Actually, yes. Facebook is usually one of the better places to share, but obviously you can do it on the other social media. Check your email on this new at-home insulin test. So thank you, Joe. I appreciate it. Wanted to try to get these to a little bit shorter, and it looks like we're going to be successful at doing that today. Richard Line. Robert Lustig mentioned that a colleague is working on the insulin test at home. Very, very exciting. Thanks, guys, for making me aware. And thanks for attending today. Looks like we're gonna get it down to about half an hour. Thank you very much. Aspen?